Good afternoon and welcome to HIT Policy Update with Dr. John Halamka, a webinar tweet chat combo from HealthSystemCIO.com. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of HealthSystemCIO.com, and I will be your moderator today. We are having a simultaneous tweet chat hosted by Kate Gamble, our Managing Editor and Director of Social Media. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or you can simply view the tweet chat in the Media Viewer panel on the right-hand side of your screen. We'll also be using the Q&A panel today, so please type in your questions as they occur to you, and we'll take them later in the program. Leave the default set to all panelists. And you can download the deck by using the URL on your screen, and that's also been sent out in the chat box. So first we're going to go 30 to 35 minutes with Dr. John Halamka, and then we are going to have our audience Q&A. Without further delay, let's turn it over to our good friend, Dr. John Halamka. Thanks for joining us.
Well, thanks so much, Anthony. And, you know, I have always tried in these quarterly seminars to produce, what are the current policy updates. And so, but today's going to be a little bit mixed because there's stuff happening in government, and that's certainly stuff we'll discuss, but there's stuff happening in industry. And certainly we can't go without a day picking up the New York Times and reading about blockchain this and Bitcoin that. So I thought it important as part of our policy discussion today to also try to clarify for folks a little bit about blockchain. And you will see a very nice article in the New York Times today about it. So let us get started. So today's agenda, I'll cover where are we with what I'll call successor to meaningful use. Where are we with what should have been stage 3 at this point, certification attestation, because there's a lot of confusion about the timelines and what you have to do as an eligible professional or hospital, so I'll clarify that. We also now have the European Union's General Data Protection Regulation, the GDPR, and that, of course, as you'll see, has an enormous fine and penalty for noncompliance. And how should we in the U.S. start to think about that, and how does it impact hospital operations and research? I'll talk about some emerging cloud and mobile applications we're seeing, some new introductions from Apple, and then blockchain. So hopefully lots of good, useful stuff. So I chatted with some folks at CMS, and I asked the CMS administrators, could you give us definitive guidance for hospitals and eligible professionals on what they will need to do over the course of the next 2 years? And here's what I heard back. In the calendar year 2018, CMS will have a 90-day attestation period for, in effect, the successor to meaningful use, which is now called promoting interoperability. And what does that imply? I mean, let me give you some exact dates. If you only have a 90-day attestation period, that means that could be October 1 through December 31. So you actually don't need your certified EHR deployed in a configuration for measurement until October 2nd of 2018. So this is useful information because if you're in the middle of an upgrade or an update or an EHR replacement, you really have till October 2nd of 2018 to get that done. So that's great. And what kind of EHR do you need? Well, remember, there are 2 certification steps. There's the 2014 certification. That was sort of the stage 1, 2 stuff. And then there's the 2015 certification edition, which was the stage 3. And the 2015 has a fair bit of complexity associated with it, patient-facing APIs, and some functionality around doing things like population health. That it's just a little different. And so for 2014, that basically means your meaningful use stage 1, stage 2 edition can be used for your 90-day attestation in 2018, and you don't even need it working until October 2nd. For calendar year 2019, there will also be a 90-day attestation period, and you will have to upgrade, go to that 2015 certified edition if you haven't already, and many, many sites have already done that. As I say, it will have things like the patient-facing application program interface and some other functionality. And so I guess what's kind of interesting is that I asked, well, what will the attestation criteria be for 2019? And CMS said, we don't know yet. And so there'll be an IPPS final rule issued, presumably in the next couple of months, which will outline those criteria. So just assume this, if anyone asks you, meaningful use has been replaced with the Promoting Interoperability program, really for 2018, you don't need to do much, it's just very simple attestation criteria, same as the past, and you can use your existing DHR from the past. One tiny caveat, just in case you hadn't seen this, one small change in attestation for 2018 is that it used to be that inpatient e-prescribing for discharge medications was optional. In 2018, it's required. So you might find yourself in 2018 asking for a hardship exemption if it's just not something you're prepared to do, and obviously CMS will consider that because that was a change from the last attestation, but that's really about it. For 2019, you do have to upgrade that EHR to at least 2015, and the criteria you'll have to attest to are not yet known, but hopefully will be in the next couple months. And what about for clinicians? Well, there's sort of two flavors of program. Remember, there's the Medicaid program, also called Promoting Interoperability now, and that similarly is going to be a 90-day attestation period, and same sort of deal, that you can use your existent 2014 certified EHR in 2018, but you need to use the 2015 certified edition by 2019. And the same is exactly true if it's not the Medicaid attestation, but the Medicare attestation as part of MIPS. And again, everything's been renamed across both eligible professionals and hospitals to Promoting Interoperability. And I think this is good because you do have on both hospitals and eligible clinicians timing and a little runway to plan if you need to do either changes in your EHR or changes in behavior based on the attestation criteria. So let's talk about GDPR, right? So here we have this European privacy regulation, kind of HIPAA plus, now for Europe, and there's some things about it that are quite stringent. So it requires consent of subjects to gather their data. So Anthony, I don't know about you, but over the last couple of months, what percentage of your email box has been filled with new privacy notices from every website you've ever signed up for in your life? It's like, oh my God. Yeah, you know, who knew I had so many accounts on so many websites? And then the data they collect about you, even with your consent, needs to be stored in a de-identified fashion to protect your privacy. And if there's data sent across borders, special handling and protections are enforced. And here's the kicker, right? I mean, Anthony, what do you see as, because you write about this stuff, typical HIPAA fines of an institution for spilling data? You know, $1 million maybe?
It's pretty big.
A look at GDPR. It's 20 million euros, or 4% of your annual worldwide revenue. So imagine if you're Google or Amazon or Facebook, and a privacy breach would result in a penalty of 4% of, you know, $500 billion. So the breach penalties are huge. But what do we do in healthcare? And I guess this is an interesting question. I think it's clear if, let's imagine you had a research collaboration where you were sharing data with collaborators in Europe. And it was truly patient data gathered in Europe, and you were sharing it across borders, and you were doing clinical trials or clinical research or drug development. You know, pretty clear that GDPR would apply. And so what we've done at Beth Israel Deaconess is we've really trained our research community that this is a very important regulation. They need to pay attention to it. They need to put protections and risk mitigation in place. So it's been a very significant educational effort for our research community. Where it gets a little bit more murky is in the clinical care delivery. So imagine, Anthony, you're in New Jersey, right?
Yes.
So a patient comes from Germany and gets care in New Jersey. And that urgent care center gathers data about this European, but delivers the care in the United States by a U.S. physician in the context of a U.S. billing system. And, every aspect of the service and the data is U.S. What if there's a breach? Does Germany sue the United States? Right? I think this is just where it's a little bit murky. So I think the guidance I'd give you is clearly where there's collaboration and research and drug discovery, absolutely. Where it's clinical care, I don't think we've really got case law or interpretation that says a European citizen's data is gathered and processed in the U.S. and if breached that there's a penalty. I don't think we really know that yet. So I see a lot of organizations just watchful waiting, thinking, planning, educating, and that kind of thing. So GDPR, certainly a big deal if you're a company like Google, Amazon, Apple, etc. If you're a single hospital in New Jersey, it may not apply. We'll have to watch. Well, here's an important trend that I'm seeing all over the world. And that is, Epic, Cerner, Meditech, Athena, they're all fine, and they're creating EHRs. And are those EHRs going to be where, in the next couple of years, where the significant innovation happens? The answer is maybe not. You're going to see it in the 26-year-olds in their garages creating apps, cloud-hosted services, things that layer on top of existent EHRs. And so I hear pitches every day from young people about, I've created this new app to help you get to your appointments, and it automatically interfaces with Uber and Lyft. I've created this new medication safety cloud-hosted service that helps you figure out if you're getting the right medicines for the right disease at the right time, or a cloud-hosted service that layers on top of the EHR and looks for variants in opioid prescribing as part of a total opioid control program. So, our friends at Athena, they have their More Disruption Please program. Epic has App Orchard. Cerner has done Smart on Fire. So you're just seeing this explosion of innovations in the app space and in the cloud-hosted services space using the FHIR standards, these fast healthcare interoperability resources, to link data in and out of your EHR transactional system to these new apps and services. And do that so the workflow is seamless. Because we all know clinicians aren't going to want to leave their EHR, but if in fact they have something that gives them a seamless integrated workflow experience, then that's fine. And I just highlight, it's sort of interesting, Anthony, you probably wrote about this, but just like 3 days ago, there were a series of announcements all on the same day that Allscripts had allied with MedAware, an Israeli company providing cloud-hosted medication service APIs, and they are just all integrated into Allscripts. And Greenway said, we're aligning with Cardio, and that's got a bunch of Internet of Things data flows and APIs. And InterSystems Premier Blue Cross said, we're going to build cloud-hosted services to aggregate clinical and financial data and provide unique data visualizations and decision support. So in just one day last week, you can see 3 alliances announced, all with this concept of building new functionality around existent EHRs. And why would anyone want to do that? In addition to reducing the burden of data entry and enhancing the experience for patients and providers and payers, there's an economic incentive to think about it too. So we didn't discuss this our last quarterly presentation, but as part of the February 2018 Bipartisan Budget Act, the Chronic Care Act, it's actually built into the budget, is a set of telemedicine, telecare policy refinements. And so it does such things as relaxing geographic and facility type restrictions under Medicare fee-for-service for telestroke. So this means it's making it a whole lot easier for clinicians to bill out professional fees or facility fees for the delivery of telemedicine services from a variety of locations. And this act also added telehealth dialysis. It also included, oddly enough, homes to be an originating site for telemedicine telecare, and clarified that Medicare Advantage can offer telehealth as part of a basic benefit plan. And there's no longer a rural-only limitation in ACOs. So you can just see this suite of changes in February 2018 suggests that reimbursement for telemedicine telecare, the use of new apps and cloud-hosted services, is suddenly going to be much more fluid than ever before. I think that's really important because I think the future will be paying for wellness, paying for quality, paying for outcomes, and not just more heads in beds. And you therefore want our financial reimbursement system to reimburse for those low-cost services rendered in the home and not simply just the expensive hospital care. So that combination of cloud plus mobile plus reimbursement change, I think is a very powerful trend to watch. Lots of startups certainly focused on that. Well, even Apple, Amazon, and are getting into the game. And no, Apple, Amazon, and Google are not going to create an EHR replacement or something like that. That's not what they're doing. They're creating middleware containers for the ability to do analytics or collect data. And think of them as platform providers. They don't have huge healthcare domain expertise, but they do have unbelievable platform capabilities. And so what do I mean? In iOS 11.4, on every iPhone in the world, there is now Fire-based Argonaut implementation guidance built into the phone. So if you go to the Health app and go to Medical Records and click the Get Started button, you'll see that based on geolocation, your phone will show you all the hospitals and providers around you that have data you can access on your phone. And if you have appropriate authorization credentials, you have medical records in a doctor's office or hospital or urgent care, you touch a few buttons and all that data now comes to a secure container on your phone. It's fully encrypted and biometrically accessed using either your fingerprint on iPhone 8s or facial recognition on iPhone 10s. And I think the key point to realize is none of that healthcare data goes through Apple, right? This is a container on your phone with a set of APIs and standards on your phone that talks directly to the data source itself, the doctor or the hospital. Apple has absolutely no interest in storing your healthcare data, analyzing your healthcare data, or being a business associate. Anthony, years ago, I was on the board with a couple of folk overseeing the Google Health project. Do you remember Health?
Yep.
A great idea, ahead of its time by about a decade. And back then, lawyers spent a lot of time and energy figuring out if Google had to be a business associate, if it was going to offer you some kind of container for your health data. And ultimately, the lawyers decided no, because Google was simply giving you a tool by which you could hold your data under your control where it would not be sold or monetized or mined. And Apple has very much the same approach. It's your data. You do with it what you want. They're not going to touch it. They're not going to influence, and they're not going to store it. It's just you, your doctor, your hospital, and your phone. And why is that an interesting idea? Well, imagine, Anthony, you woke up this morning and said, boy, I am really interested in how to optimize the use of a CPAP machine. Let's just make What if some entrepreneur was able to create an app that sat on your phone and examined all your personal healthcare records and the Internet of Things data from the pulse ox you have in your home, your blood pressure cuff, and other devices, and then was able to offer you custom advice. And that's not an Apple product. That's a third-party entrepreneur creating a unique app, and you, of course, have to approve it. And you have to say, app, yes, you are allowed to access my Internet of Things data or my medical record data, and I grant that to you, knowing you could change that at any time. So you're going to see a huge explosion of innovative apps sitting on the phone that are going to be able to interpret the healthcare data that you aggregate there. And so you're going to see, I believe, in the next couple of years, it's not for everybody, but for some people, the emergence of patients being their own data stewards. It's going to be a lot like India, right? In India, the patient carries the record from doctor to doctor, the doctor writes on it, and the patient takes it away. The doctor doesn't hold any of the data, the patients and the families do. And I can just imagine, if you're going to see a PCP, a specialist, an ED, an inpatient stay, a skilled nursing facility, and all that data is fractured all over 5 different EHRs, but in one place on your phone, you don't have 5 portals anymore. You have one container with one set of longitudinal data, your lifetime healthcare experience, stored in a patient-centric way as a time series, and you can share it as you want. If you want to share it with a cool app, great. If you want to share it for clinical trials and clinical research, that's completely fine. If you want to share it with a family member, totally up to you. And the Office of Civil Rights has issued important guidance, which says if a covered entity, a hospital, a doctor, a payer, sends data to the patient, at that point, the patient can do with it what they will, and no covered entity would ever be prosecuted for a privacy breach, right? If the patient puts the data from Beth Israel Deaconess on their Facebook page, the Beth Israel Deaconess would not in any way be accused of a breach because the patient was the steward of the data that we securely transferred to them. So there you go, kind of nice that you're going to have empowered patients and families and a regulatory environment which ensures that those data sources, those data producers, will not be prosecuted for anything done with that data as long as it's given to the patient in a secure fashion and the patient takes action on it. So certainly something to watch. You're going to see that on all the iPhones, and I'm sure you're going to see further developments from Apple, but I have to guess that many other companies will offer similar products and services. Well, let's talk about blockchain. So you hear, oh my God, blockchain is going to replace databases, analytics, EHRs. In fact, it's going to replace money. It's going to be wonderful. Well, what is blockchain? Remember, blockchain was invented because many folks don't trust government or single corporations, right? Single corporations could go out of business. Single corporations could spill your data. And so putting all your eggs in a centralized basket of government or industry doesn't seem prudent. The idea with blockchain is build thousands of independent actors, thousands of unrelated parties processing data and storing information. And it's really impossible to commit fraud because you'd need 12,000 co-conspirators. So the idea is it's a non-centralized infrastructure of software for which you can post data to this group of independent actors, but never erase or alter it. And so, in effect, it builds trust based on consensus of thousands of independent actors, and there are various methods that are used to enforce that trust. There's proof of what's called proof of work or proof of stake. You did computation to prove that data had integrity. You put a lot of resources into the effort. You can be a trusted party to this group of folks holding data in a distributed fashion. But most importantly, what it does to build trust He uses a cryptographic model that makes data alteration impossible. And what do I mean by that? Now, Anthony knows I'm a vegan, so I really, really hate to use this example, but it illustrates the point. So, imagine I have a cow, and from that cow, I make corned beef hash. Anthony, I think you would very much agree it's going to be hard to turn the corned beef hash back into a cow.
Difficult.
Right? Yeah, difficult. So the idea behind blockchain is we use a one-way transformation of the data that is unreversible. And if I have a data set, and I do this one-way transformation, and I put that one-way transformation in a public ledger with 12,000 individual parties, and I can prove that the data that I'm holding and that one-way transformation, it's public, it's known. If I ever altered the data, the one-way transformation wouldn't work anymore. I actually have trust that there's data integrity, lack of alteration. Nothing has been deleted. Nothing has been altered. It's all a one-way transformation that's unreversible. It provides a way of just not ever faking data. And so why is this interesting? Well, what if I have a medical record and somebody worries about it having been altered? Well, I could do this one-way transformation in the medical record, put it to the blockchain. 20 years from now, you'd find that the data I have and the blockchain single transformation, they all match. It shows you that the record is completely intact. And so there's this sort of proof of audit trail or proof of data integrity. And there may be other use cases for it, like what if in clinical trials we're worried that somebody faked a clinical trial? What if the FDA operated a blockchain where the second you finished a trial, you did this one-way transformation of your notebook, and your notebook was posted to the blockchain, and you could prove the notebook wasn't altered ever? So as you can see, it's not going to replace EHRs. It's certainly not going to be something that is used for every potential use case of healthcare information exchange or such things. But for simple things like proving data integrity or auditability, the idea of blockchain is actually probably sound. And note that I didn't talk about cryptocurrencies. Bitcoin, Ethereum, Litecoin, they all sit on top of the blockchain. They're very separable from the blockchain. So I hate to use a simplistic conclusion, blockchain good, Bitcoin bad. But blockchain has utility as a technology, and cryptocurrencies are fraught with peril at the moment. So I'd be very careful of initial coin offerings or investing your hard-earned cash in a cryptocurrency. So there you go. Of course, Anthony, we'll turn it back to you and our sponsor, but I look forward to your questions and our discussion.
You got it. Well, we're going to jump right in to our discussion today. First question is, do you feel certification is still necessary and helpful to the market?
Well, what a really interesting question. And so I'm going to answer that probably, Anthony, in a very controversial way. No.
And I did not set up this question with Dr. Halamka beforehand as a softball. Go ahead.
Yeah, so certification was really important when we first got started. And why? Well, because you remember back at the beginning of the Meaningful Use program, people were running their brother-in-law's medical record written in FoxPro. And, it was probably not fit for purpose if you wanted every hospital and doctor to have, let's just say, a floor, right? We're not telling you that you have to have flying cars. You at least have to have a skateboard. And so certify that there's at least some basic functionality there. And then what do? We got rid of a lot of the chaff. Right? We got rid of a lot of the ancient technologies, the obsolete legacy systems. And that was good. It was a fine way of bringing a floor to the industry. Problem with certification, it's really time-consuming. It's really hard. And so I can tell you, having been certified for all of our medical records we self-built, I had to take people off of innovation projects and put them on certification projects. And so I would say, I guess I would rather government say, here's an outcome we want you to achieve, but you can achieve it however you want. Cloud-hosted, app-based, people going to door with clipboards, don't care. Judge me on my outcome, my quality, my safety, and not an arduous certification process going forward, because as I say, I think in the future, certification processes will actually impede innovation by drawing resources away from the things that customers really want done.
Very good. A little more on that. Do you think vendors are getting enough of a timeline on evolving certification requirements to prepare? I know this was a big issue earlier in the meaningful use program where some things were moved, I think, because vendors just simply were not being given enough time to put in the things they were asked to put in.
Yeah, so it's not so much a problem today, right? It was definitely a problem as we went from stage 1 to stage 2 and planning for stage 3. The way I describe those timelines, I know this may not be the best analogy, but it was like asking 9 women to have a baby in a month, right? It doesn't work that way. You know, there's a certain gestation time you need, and you can't shorten it. And so I felt like the vendors were asked to do too much too fast in the interest of being on this treadmill of timeline. And what you ended up with was no focus on usability. And that's one of the reasons why we have many of our EHRs are hard to use, burdensome, and not human engineered, because they were so focused on these aggressive timelines, they didn't have time for usability. But now, since, as I mentioned at the beginning, we have a 2015 certification rule, you kind of know what that's all about, you've had plenty of time, and maybe the challenge will be if we don't yet know what hospitals have to attest to in 2019, it's not a vendor problem, but it could be a hospital problem if you need to radically change workflow and behavior for whatever new attestation criteria are published.
Very good. Is Google Fit going to catch up with Apple Health Kit anytime soon?
Yeah, very, very challenging to predict what middleware or apps are going to catch on. But what I'm seeing is there's such agility, such rapid innovation that I would guess, not only Google and Apple will be part of the mix going forward, but you're going to see startups we haven't even heard of yet competing in that space. And that's great, because we used to have EHR release timelines of 18 months. Now, you get an app every 18 minutes.
Yep.
So I would say I'm not going to play favorites in that race. I'm just going to say I'm going to embrace the idea that mobile apps, cloud services, and FHIR will give me choice. And it'll be very modular, and if I don't like something today, I can replace it tomorrow.
Very good. Do you see value in all facilities having to produce the common clinical data set?
Well, good questions today. So why do I think that that's important? Yeah, the common clinical data set is absolutely not your full medical record, but it's a floor. And what I found in our ACO is that if I tell every one of our 3,000 doctors who are running 6 different EHRs, right? We don't own these guys. We're contracting for them, providing services for them. I need the common clinical data set in order to measure quality, to measure outcomes, to benchmark you. It turns out there's very little resistance to the exchange of a common clinical data set because every EHR must produce it. So I sort of think the general answer is if we want better data liquidity, if we want to reduce friction and cost, requiring every EHR to at least produce some common data set's a good thing.
Very good. Will government programs help us reach true interoperability, and I know you're going to want to define that, in the next few years?
Okay. So you probably heard me say this before, Anthony, but I was talking to one of our leading senators. And I said, Senator, what is it that you think interoperability is? And that senator said, every data element in your lifetime medical record exchanged with every stakeholder for every purpose in real time for free. Well, I would argue if that's your definition of interoperability, it will probably be the next generation that solves that one, not this one. I think of interoperability as having the data you need in front of you in order to make a reasonable care decision. And so that may only be a few hundred data elements, and it may not be in real time for free with every stakeholder. And again, slightly controversial thing to say. I think there was a time for government, and that was to get everyone off paper and onto electronic health records and to build a floor of functionality. But 2018, I don't think it's about government. I think it's really about private industry innovating and alignment of economic incentives so that we're going to see the agility from these apps and cloud services that could have never come out of a government program. ONC, certainly is emphasizing and is a cheerleader for the idea of patients getting access to their own data. So that's good. Government is cheerleader, government is convener, fine. Or with the Telemedicine Chronic Cares Act that I talked about, clearing the policy barriers away so that private industry can innovate faster. That's good. But government as innovator or government leading the charge or government setting the agenda, I don't think that the next couple of years are probably the right time for that.
Very good. Will patient advisor smartphone app companies who analyze PHR data and recommend course of care require medical professional licensing?
So a really interesting question. Bill Maisel at FDA issued this guidance as to what requires regulatory approval. And what he said was this: we're going to stratify all apps into 3 different categories. Category number 1, wellness. Anthony, eat less, exercise more, and no more sports. Is going to require any kind of regulatory guidance around that. Administrative. You have an appointment coming up next week, go to it. No one's going to require guidance for that. Oh, I've just analyzed your CPAP data, and I highly recommend you completely change all the settings on your device. That has a very high risk, and therefore that will require regulatory oversight. So, whether there's a license, maybe not, but regulatory oversight for diagnostic and treatment advice, yes.
Very good. If CEHRT were to go away, as you suggest it should, where and how would a CCDS be required?
Okay. So let me tell you what I have. So I was just trying to figure out how many more acronyms you would use. To restate the question, if we don't require a certified EHR, well, then how do you get data flowing, and especially a common clinical data set? So what I did for my docs in the Accountable Care Organization is I said, I don't care how you gather the data. I don't care who enters the data, but I do require that you submit the data as part of our contracting relationship. So again, it's outcomes focused. The outcome in this case is that data is submitted, but I don't really give you the detailed requirements as to how you must do that. Maybe a weird analogy is that imagine that we say you must be able to play music. Whether you use a phonograph and vinyl or an iPad with a Bose speaker system, I don't care, as long as you can play music.
Very good. Do you think something similar to GDPR will be passed in the U.S.? What could it look like and when could it be enacted? And should hospitals assume something like this and skate to the puck in some fashion?
Wow, that's a tough question. I think you're going to have to guess that we are going to need to enhance our privacy frameworks for several reasons. So first, as you know, state law preempts HIPAA, so some states are more rigorous. And every state, therefore, seems to have a different variation on what is consent. What do you do with HIV data or substance abuse data? It's extraordinarily confusing. And how are you going to do machine learning and AI and gather data across the entire country for the improvement of care if every single state has a different set of guidelines for doing that? So fine, we're going to need something more uniform. I absolutely agree. And in the world where we see Facebook breaches and things like that, I think people are waking up to the fact that all these services they thought they were getting for free aren't free. You know, the price is giving up your privacy.
Right.
And therefore, having a bit more guidance as to what's the protocol. If you can give up your privacy if you want, but there's got to be a protocol for doing it. So sure, I mean, I think there's going to be national guidance that is refined to give patients better control and choice. Whether it'll be GDPR, that I'm not quite so sure, but certainly something beyond what we have today.
Very good. We did a webinar Tuesday this week on the opioid crisis, so I wanted to get your thoughts on the role of HIT professionals such as CIOs in addressing the crisis, and if you are familiar with any policy-related activities taking place around it that you want to share.
Yeah, sure. So what do we do at Beth Israel Deaconess? So first step was you change your formulary. You change your guidelines and pathways and protocols so you're not putting opioids as a default treatment, right? Because it turns out in 90+% of the cases, you actually don't need to use opioids. You know, we were just, I mean, the healthcare system was by default handing out prescriptions post-op or dental procedure that it probably didn't need to do. So change your guidelines, pathways, and protocols. And then start using things like prescription drug monitoring systems. States have these things. Integrate them into workflow. So if a patient is requesting an opioid, the doctor in front of them has a history of every opioid they have ever had prescribed or dispensed, and then can use that for guidance. Note that there will be people who become dependent on opioids, and chronic pain syndromes may require that. And if so, you need to develop contracts. What are the pain management contracts with individual patients for their consumption of these opioids? So we made fully electronic contracts between patients and caregivers, which are then viewable by all people on the care team. And that's tracked against prescription drug monitoring data to make sure that the contract is successful. But then finally, something that is a new adventure we're just starting is using a machine learning approach to look at provider and patient variation in expected opioid use. See, this is a little tricky, right? Because you're going to look for someone who's prescribing more than they probably should, or a patient who seems to be taking and refilling more than they probably should, and you really have to do pattern recognition and not just rules, because it may be the pain clinic that is prescribing more, or a person in a given region where there's a lot of industrial injury or whatever. And so we're in effect creating dashboards for early alerts where there seems to be variance.
Very good. Any thoughts on the proposed trusted exchange framework and common agreement?
Sure. So remember that the trusted exchange framework and common agreement has two sections, and we talked about this, I think, our last webinar. Section A, which outlines goals, and Section B, which outlines the methods to achieve those goals. I thought the goals were really well stated, but to the other question you had about government, I think that Section B got a little too prescriptive about the how. So sure, let's hope that TEFCA going forward focuses on the goodness of the outcomes we should achieve, enhances patients' access to their own data, the use of APIs, but doesn't necessarily specify how individual hospitals and practitioners need to implement that.
Very good. Well, those were our audience questions, and I think that's about all we had time for today. When you close out your WebEx window, you're going to be taken to a post-event survey. We'd appreciate you taking a moment to answer it. Regarding continuing education, attending our events gets you 1 CEU for the CHIME CHCIO certification program. If you are in that, please let CHIME know you were here, and if you've asked us to do so, we will. You'll receive an email when the archive recording of this event has been posted to YouTube. If you'd like us to produce a webinar on the topic of your choice, you can reach out to Nancy Wilcox from our team, and you can go to our website to view our upcoming schedule. So with that, I want to thank our good friend, Dr. John Halamka, for joining us. I want to thank you, our attendees. Everybody have a wonderful day.
Thank you.